Assalamu alaikum wa rahmatullahi wa barakatuhu. Hi guys, this is Shahadat and welcome to the fourth part of this video series where I'm reading this scientific paper for you. This particular paper was published in the openaccessjournal.com in the diabetes management section. The title for the paper is A Clinician's Guide to Inpatient Low Carbohydrate Diets for Remission of Type 2 Diabetes Toward a Standard of Care Protocol. The paper was authored by Mark Cucuzzella, Adil Haidt, Caitlin Patterson, Laura Saslow, and Rory Heath. So this is the fourth part, and I have so far read up to this initiating dietary intervention section. So in this video today, I'm going to start reading from here. Okay, so without further ado, let's start. Initiating dietary intervention. The patient's dietary order as an inpatient in the hospital should be changed to limit carbohydrate intake to 10 grams per meal. To increase adherence and reduce perceived hunger, the dietary order may also include instructions to double eggs, meat, fish, salad, and eliminate all sugar, starch, and sweet drinks. This may require some education for the hospital food service. Importantly, for hospitalized patients, this is not a weight loss or calorie-restricted diet. It is a diet for approaching normoglycemia and reducing medication requirements for controlling blood glucose. In most cases, sodium should not be restricted because natriuresis occurs with carbohydrate restriction. Many patients will experience lower blood pressure within several days of initiation of the diet, and some will experience this immediately. In this setting, post-meal blood glucose testing can serve as an educational opportunity to demonstrate to patients that if they do not eat carbohydrate-dense foods, such as sugars and starches, their blood glucose does not go up with meals, even without the administration of insulin. Next section, medication management. See Appendix 3 for an overview of medication reduction guidelines for following patients with T2DM on a LCK dietary intervention. This table demonstrates the alteration of medications that will be necessary during treatment of T2DM with a LCK diet. As the diet continues to reduce blood glucose and insulin resistance, hypoglycemic medication must be carefully monitored and titrated to prevent hypoglycemia. No sliding scale insulin is needed to cover meals, as patients will not be consuming significant amount of carbohydrate foods at mealtime. Short-acting insulin may be needed to correct blood glucose excursions over 200 mg per deciliter and bring them down to 150 mg per deciliter range. The immediate goal is not normoglycemia, but to wean patients off of insulin or other hypoglycemic medications. In this context, short-term mild hyperglycemia is safer than hypoglycemia. For patients with T2DM who have some remaining beta cell function, the healthcare team should consider changing long-acting insulin to morning-only glargine or Lantus, Dietary or Levemir, or NPH insulin. Note, none of these are 24-hour insulins. Morning dosing fits better with normal circadian and meal patterns and allows reduced insulin load at night. This dose should be reduced to no more than 40 units even if the patient is on high dose long-acting insulin at home. Patients with beta cell failure will need a split dose of long-acting insulin. Patients may be weaned from long-acting insulin and have it discontinued entirely if blood glucose levels are consistently low. Hypoglycemia is rare with low-dose long-acting insulin in the morning. Sulfonylureas and insulin secretagogues should be discontinued immediately as directed in Appendix 3. SGLT2 inhibitors pose a risk for euglycemic acidosis and therefore should be discontinued. The healthcare team may consider adding an insulin sensitizing agent, for example metformin, if the patient is not already taking this. This is contraindicated if eGFR is less than 30 milli per minute, but 30 milliliter per minute, but in the impaired range of kidneys, estimated glomerular filtration rate, or eGFR, 30 to 45 milliliter per minute, a discussion of risk and benefit should occur. Blood pressure often improves on LCK diets. Symptoms of orthostasis, systolic blood pressure below 120 or diastolic blood pressure below 70 is an indication to wean patient from antihypertensive medication. Diuretics are problematic as carbohydrate reduction induces natriuresis. The healthcare team should consider tapering these immediately unless indicated for symptomatic heart failure. Renal protective antagonism, renal protective angiotensin converting enzyme, or ACE inhibitors, or angiotensin 2 receptor blockers, ARBs, should be continued if proteinuria is present, unless patient develops hypotensive even on low dose. Patients should also be taught home monitoring of blood pressure so that medication can be adjusted daily. When making any significant dietary change, the healthcare team should closely monitor drugs with a narrow therapeutic window, such as some seizure medication, digoxin, or antibiotics. Next section, adverse effects and supplementation. The most significant adverse effects from LCK diet originate from over-medication with hypoglycemic and antihypertensive medications following a dramatic dietary change. See Appendix 3 for how to safely reduce medications when a LCK diet is initiated. The insulin-lowering effect of a LCK diet can reduce the resorption of sodium and other electrolytes in the kidney. Sustained loss of salt via the urine can contribute to hypovolemia and feeling of fatigue and lethargy that some patients experience when transitioning to LCK diet. It is recommended that patients on LCK diet consume normal amounts of salt, around 4 to 6 grams per day. Bouillon may be ordered for the patient for this purpose, but it should not be low sodium. Further supplementation with magnesium may also be helpful for patients and should be considered on an individual basis. See Appendix 1 for more details. Good hydration with water is essential, most often over 2 liters a day. Some historical examples of low carbohydrate diets have greatly restricted the intake of a variety of foods, and supplementation with a multivitamin is often suggested in those cases. The LCK diet for T2DM treatment described here emphasizes a wide variety of plant and animal foods with high nutrient density. This diet will provide adequate essential nutrition for the majority of individuals. The recommendation of multivitamin supplementation should be on a personalized basis for the patient and is left to the clinicians and patient's discretion. Individual testing of vitamin D, B12, folate, and magnesium can guide supplementation. Supplements containing medium-chain triglyceride, or MCTs, are often a part of ketogenic diet for neurological treatments such as epilepsy. The MCT contained in these supplements are readily absorbed by the liver and converted to ketone bodies. Supplementation of MCT is not recommended for the treatment of T2DM, whereas the goal of MCT supplementation with ketogenic diets for epilepsy is to create high levels of ketones for therapy. High levels of ketones are not necessary for dietary treatment of T2DM. See Appendix 1 for additional information about treating side effects that may occur during the transition to a LCK diet. Although not a contraindication to LCK diet intervention, history of bariatric surgery or cholecystectomy may require individual tailoring based on diet tolerance. For patients with previous cholecystectomy, dietary fat will have to be increased gradually with possible bile salt supplementation for persistent gastrointestinal distress. History of gout or elevated uric acid is not a contraindication to the diet. Clinical experience has demonstrated that adherence to LCK diet may increase. Clinical experience has demonstrated that adherence to a LCK diet may decrease uric acid levels over time. Reference 35. Initiation of the diet may precipitate a flare, but will likely result in long-term improvement. Because LCK diet often involves changes in consumption of vitamin K containing vegetables, monitoring of international normalized ratio or INR should be more frequent in patients taking warfarin. I think I'll stop part 4 of the of this video here and start the part 5 from discharge and follow-up. So I hope to see you in the next video. Take care. Bye-bye.